Okay, we're going to continue on with patient assessment with step number 4. And step number 4 is our secondary assessment. And in our secondary assessment is really when our assessments start to differ. When we're going from our focused assessment or our general assessment, our assessments are going to start to differ right here. Okay? When we do a generalized assessment or a full body, we are going to look for another acronym. Okay? I call it decapitated beetles. You might call it decap BTLS, but it means the same thing. So we're going to look for decap BTLS. What does the D stand for?
Deformity.
Deformities. How are we going to look for deformities?
Look and feel.
How are we going to look for deformities? That wasn't an answer. Guys, how are we going to look for deformities?
Look and feel.
Look and feel. What?
So if their face is smashed in, you can see it.
If their face is smashed in, you can see it. Okay. How are you going to look for a deformity in their chest wall?
Feel.
Take their clothes off. Get rid of their clothes. They're just in the way. Okay. Right now, we're dealing with a general or a full body assessment. A full body assessment is for someone who is what?
Unconscious.
Unconscious or
Not competent.
how about a victim of multi-system trauma?
Okay.
Okay? They're unconscious, they're a victim of multi-system trauma, so we need to check them out. You could have a person who's a victim of multi-system trauma who is still competent, in which case, we don't want to just rip their clothes off of them.
Yeah.
Okay? You might want to rip their clothes off of them. I know what you're thinking. You're like, there might be some patients I want to do that with. But if they are conscious and they are responsive, you need to be respectful of their modesty. However, we still need to be able to look and feel everything. Okay? So we're going to look for deformities. What is C?
Contusions.
Can you feel a contusion? Can you feel a contusion? Chief says no.
Is that a contusion like a cut or something like
A brush burn or some kind of.
Yeah.
that? Yeah.
So you can't really feel them, especially if they're under the surface of clothing, right?
road
Again,
rash.
gotta get their clothes off. Take their clothes off. Take their shirt off. Take their pants off. Look at your patient. Deformities, contusions, what's A? Anyone? A is abrasions.
Abrasions.
What's an abrasion?
That's great.
It's a scrape. It's like road rash, right? Kind of messes with the surface of the skin. Might be a little deeper than capillary, but you get minor oozing, minor bleeding. Okay? What is P?
Punctures.
Punctures. It also could be what? Punctures or penetrations. What is B?
Burns.
Burns. How about T?
Tenderness.
Is this not in chapter 9? You'd finished chapter 9, right? Is this acronym not in chapter 9?
I didn't see it in that
It's
note.
probably in trauma assessment, which is like chapter 22 or 23, maybe even 24. Tenderness.
I remember that.
I thought I saw it in here.
I remember the acronym though.
That's what I've been trying to find this whole time.
Andy's talking to me. He said Vincent's been taking Tupperware out and handing it to him while he's screaming his head off, pretty much.
What is the L?
Lacerations.
Lacerations. And the S?
Swelling.
Swelling. Okay. When we are doing our head to toe assessment, we need to be looking and feeling for all of these things. When we do our head to toe assessment or full body assessment, where are we going to start? Well, it's head to toe for a reason, guys, right? We're going to start at the head. And what are we going to assess in the patient's head?
The face.
You're gonna feel the head to see whether or not there's any soft spots or if there's any bleeding, or any other irregularities.
How are we going to check the
Sorry.
eyes? What are we going to do with the eyes?
Why'd you put
Check
a
the
light in it?
pupils.
Yeah, we're going to check the pupils. How are we going to check the pupils?
With the
Flashlight.
penlight.
And what are we looking for with our handy-dandy
Dilation.
little pen light?
Dilation.
Dilation?
Pupil.
Are we going to get dilation when we introduce light?
Oh, the one that makes it smaller.
The one that makes it smaller. What makes it smaller? What's that called? Constriction? Your pupils do one of two things. They dilate or they constrict. If they're working together and they're doing the same thing together,
That's a good thing.
it's a good thing. If they're not doing the same thing together, what does that indicate?
Concussion.
Possibility of head injury.
Possible head injury.
And the side that's
Yeah.
not making sense, the injury is probably going to be on the opposite side.
Yep. Okay, what are we going to look at in the ears?
Blood or drainage.
Can you see it through there, Adam?
Oh my god. Really?
What kind of blood or drainage might we see coming out of the ears?
If they have
What kind?
Well, it's either blood
Well,
or you could
and-
have CSF.
You could have CSF. How are we going to tell if we've got CSF coming out of the ears? What is CSF?
Cerebrospinal fluid.
Cerebrospinal fluid. And how are we going to tell if the fluid that's coming out of the ears is CSF or has CSF in it? Guess what? We'll study this more when we get to the head injuries chapter. But if you take some gauze, and you put the gauze next to the drainage and you pull it away and you see the blood in a circle and yellow stuff spreading out from that blood, that's called the halo effect. That indicates that you have cerebrospinal fluid in the drainage that's coming out of your ear. Cool, right?
Could
A
you
bad
also
thing.
get it because of a head injury and without the spinal fluid?
You wouldn't get the halo effect. You could still have drainage out of your ear, but you wouldn't get the halo effect unless you have an injury, a basilar skull fracture that causes CSF leakage into your ear holes. Make sense? Okay, what are we going to look at in the nose?
Blood.
Is it bloody?
Is it
obstructed?
bloody? Is there stuff in the way? And what about the mouth?
Blood.
Same thing.
Same thing. We already assessed the mouth, didn't we?
Yeah.
Way back here, an airway. Why are we assessing it again over here? To make sure nothing changed and to make sure we didn't miss anything. Okay? On the head, we are also going to assess the scalp. To assess the scalp, you're going to take your gloved hands and put it all over your patient's head. Their entire head, and you're going to pull it out. You're going to look at your fingers and see if there's blood on your gloves. You're also going to feel to see if any of the bones are weak or crackly or moving around. You're taking an ENT class. That look doesn't work. That grossed out look doesn't work.
No, I was just thinking.
Okay, so we've assessed the head. What comes after the head?
The neck.
The neck. Good job. The neck. We are going to palpate the cervical spine. Why are we going to palpate the cervical spine?
You want to see if there's any deformities?
We want to check and see if there's any deformities. We might also check and see if there's any bleeding. Okay? Our patient is likely going to be laying on their back. If they weren't on their back originally, we're going to do our back check before we roll them onto a board. Okay? But we're going to check their neck and palpate the cervical spine and make sure that the cervical spine is okay. Then we're going to check their throat. What are we going to look for on their throat?
See if there's jugular vein distension or displacement of the trachea.
Okay, we're going to look for tracheal deviation or JVD. These terms don't mean anything to you right now. They will. Okay? I promise they will. When we are done checking out their throat, what's the next part? Chest. What are we going to look for on their chest? What are we going to do?
Cut their shirt.
We need to take their shirt off. If we haven't already taken their shirt off over here, because how are we going to manage injuries to breathing if we haven't taken their shirt off?
Yeah.
Okay? If we haven't taken their shirt off over here, we better darn well be doing it over here. So, we are going to palpate the chest. And we're going to auscultate. What does auscultate mean?
Listen.
Means listen. So we're going to auscultate the lungs. Why do I care what their lungs sound like?
Because if there's anything in them besides air, you're going to want to know about it.
So if there's anything in it besides air, I'm going to want to know about it. Also, if I can't hear their lungs, is that a problem?
Yeah.
Yeah.
Might not be air.
Okay, what comes after their chest?
Abdomen.
Abdomen. And I'm going to palpate their abdomen. How am I going to do that?
In 4 quadrants, you're going to take your hand flat, you're going to press, and then you're going to let go. If it
And
hurts,
what am I looking for, Chief?
you're looking for tenderness, guarding or rigidity, or distension.
Okay. We're going to check all 4 quadrants. You can look for some of these things. You can look for guarding. You can feel rigidity, okay? You can't look for tenderness. You have to feel your patient if you're going to feel tenderness, or if they're going to report to you tenderness. How are you going to know if your unconscious patient has a problem with you touching their abdomen?
They'll probably resist you.
They're probably going to try and resist. Even if they're unconscious, if they have tenderness in their abdomen, it's likely that they are going to guard or they're going to pull away from you.
They can do that if they're unconscious.
You'd be surprised what people will do under unconsciousness. Actually, people sometimes wake up when there's enough pain, they come out of unconsciousness.
Very true. What comes after abdomen?
Pelvis.
Pelvis. We're getting to the pelvis. What are we checking for in their pelvis? We want to make sure their hips are stable. How are we going to do that? How are we going to make sure that your hips are stable?
Put your hands on them and press down slightly, and then press in slightly, and you're feeling for any flex or crepitus, which is to say bone ends grating.
So we can do it either down and then squeeze, or you can squeeze and then press down, but your hands are going to start on their iliac crest. Can you find your own iliac crest? Do you know what your iliac crest is?
It's your hip bone's right here.
Oh, Mr. Godet is hidden.
I
And
thought
kids
we lost
working
him
on
in the cornfield.
speed boarding today. What?
I said I thought we lost him in the cornfield.
We probably lost him in the cornfield. Okay, the part of your iliac crest that you can feel is this part right here.
Yep.
Okay, you lost your party hat. Okay. Oh. Choo-choo-choo. Hi, camera. Okay, so the part of your iliac crest that you can feel is this part right here. So when you are when you're doing patient assessment and you're getting to their pelvis, you're going to put your hands on the outside of their iliac crest. You're going to squeeze together and you're going to push down. They're on their back. So when you push down, you shouldn't feel any movement. If you do, you feel movement like this or you feel movement like that, you got a problem with their pelvis, folks. And guess what? People can bleed out here. So we got to stabilize their pelvis if there's a problem there. If you don't feel it and you don't appropriately assess it, you can't appropriately treat it. Say goodbye, Mr. Godet. Bye. I like Mr. Godet. He's fun. He's helpful. Okay, what else are we going to assess in the pelvis area? Pelvis. Notice I said pelvis area. I didn't say pelvis. How about genitalia?
Hernia.
Why do you think assessing genitalia is important?
Bleeding.
No, well, yeah, in men, if there's a spinal injury, sometimes they'll have a priapism,
Priapism. What is priapism?
an involuntary erection.
It's an involuntary erection. My students call it an injurection. Injurection. It's an erection that results from an injury to the spinal column. Okay? If a man has a priapism, it's a pretty good indicator that he's received some type of insult to his spinal column. What causes that priapism? Obviously, it's an injury to the spinal column, but the injury to the spinal column causes something to happen to your lower body. What is it? Okay, what happens when you get a normal erection? Welcome to EMT class, folks. What happens when you get a normal erection?
Well, stimulation
Why?
causes the brain, you get signals that go between the genitals and the brain, and the brain says, do something.
Okay,
So,
what happens to
and your blood pressure increases at that location.
your penis when you get an erection?
Goes up.
It fills with blood.
It goes up, but why? Vasodilation. Vasodilation. What is vasodilation? Yes, I just took all of the sexiness out of an erection.
The veins
Okay.
get bigger.
The veins and the arteries, all of the vessels get bigger. They get bigger and blood flows down there and it pools there and it causes it to get hard. Okay? Okay, we have vasodilation happening. If you have a spinal injury that causes priapism, that spinal injury has caused you to have massive vasodilation of the lower half of your body.
Which is also mean all the volume in the rest of you is going to go down there.
Yep, and you're going to start experiencing shock.
Yeah.
Right? Okay, so vasodilation of the lower half of the body as a result of spinal injury, also called neurogenic shock. We'll learn about types of shock later, so here's your first introduction. Neurogenic shock causes priapism. Okay, so we need to assess the genitalia to make sure that we're not dealing with priapism, because priapism is a pretty good indicator to us that there's something wrong with the spine. Unless you have a reason to look at the genitalia, don't. Okay? If they're complaining of pain there, or if you can see bleeding coming from that area, or if it's a male and you need to assess for priapism, you can look at the genital area. If you don't have a reason, don't look. Remember to be respectful of their modesty. Okay, what do we have after genitalia?
Extremities?
What?
Extremities.
Extremities. We have 4 of them. Did you know that? Okay, so after genitalia we have legs. We're going to look and feel all the way down our legs. When we get to the bottom of our legs, what are we going to check? Huh?
Pulse,
Pulse.
motor, and sensory.
Pulse, motor, and sensory. How are we going to check those things?
Feel for a pulse.
Where?
In the feet, it's going to be on the top. Pedis dorsalis,
Dorsalis, pedis, yep. Where's the other place we can check?
behind the heel.
Posterior tibial. Okay? We're going to take our shoes off later and find our pulses. Yay!
Well, I'm wearing your socks, so.
Why do you have my socks on?
I don't want to know these things.
Okay, so we're going to check for pulse. How are we going to check motor in the feet?
Can they wiggle their toes?
Can they wiggle their toes? How are you going to check sensory?
Ask them if they feel.
Ask them if they can feel it when you pinch their toe. Now, if you have a patient who's unconscious, how are you going to check motor and sensory in their feet?
They have reflexes.
They have a reflex. What's that reflex called?
I don't know, but what you do is you run your thumb down the bottom of the foot, and the foot will go like that.
Yep, and their toes will arch out like this. It's called a Babinski reflex.
Babinski.
Babinski, like baboon? Not really. Babinski, okay? It's called a Babinski reflex. Then, when you're done with their legs, what are you going to check?
The arms. Shoulders to
Feet are at the
fingers.
bottom of the legs, so
Feet.
that's kind of included.
Arms?
Arms!
Okay.
Okay, when we were up here at chest, that's when I checked the shoulders. That's all part of that same assessment. Okay, so I'll put shoulders up here. I'm going to check the arms, and what am I going to check in the arms? Pulse, motor, and sensory?
Yeah.
Imagine that. We have 4 extremities.
Feel for
We check
fractures.
pulse, motor, and sensory in these 2. Should we check them in these 2?
Probably.
Yeah. So we're going to palpate all the way down the arm. Make sure. We're going to look. Do I see any injuries all the way down? Then I'm going to check a pulse. I really like my radial pulse. I could check an ulnar pulse if I wanted to, but I don't. I really like my radial pulse. It's the strongest one in there. Okay? Oh, I found my radial pulse. Can you wiggle your fingers? Can you squeeze my hand? Can you feel what finger I'm touching? All right. All of this is a part of your secondary assessment in trauma. You also have to check their back, their thorax. Now, the best time to palpate or look at the back of your patient's body is when you're doing what?
Log rolling them.
When you are log rolling them onto
A backboard.
a backboard. Okay, so you need to remember to assess their back during all of that time. All of this part of secondary assessment, this secondary assessment, all goes along with your general or your full body. Okay? Okay, everybody done with this part? I can erase this?
Yes.
All right. The next part that we're going to talk about for secondary assessment is our focused assessment. Okay. If our focused assessment has to do with a sprained ankle, what are we going to focus our assessment on?
Ankle.
Their sprained ankle. How are we going to assess that ankle? How many times have you sprained something and I've said, can you move your toes?
A lot.
A lot. Every time you do something to your leg,
Or fall down the stairs.
something like that, right? So my assessment is going to focus on whatever your complaint is. If our assessment is medical in nature, our assessment is going to focus on the body system that is affected. What are some of the body systems that could be affected in a medical call? Look on the wall.
Plenty of systems to pick from.
Neurologic.
Neurologic.
There you go. Cardiovascular.
Cardiovascular.
Toxicologic.
Toxicologic. This is a type of call rather than a body system, but it's close enough.
Psychologic.
Psychologic.
Endo.
Endocrine.
Endocrine.
Okay. If you have a medical call, you're going to focus on a system. Toxicologic really isn't a symptom, it's more a type of call. Okay? So we're going to get toxicologic out of there. But all of the rest of these, oh, we forgot reproductive. All of the rest of these could be the system that you need to focus on for your secondary assessment, for a focused assessment. Okay? Okay. During your secondary assessment, whether you are doing a trauma assessment or whether you are doing a medical assessment, this is the time to get vital signs. Okay, so at this point we need to get vital signs. And the first set of vital signs that we get is called what? The very first set of vital signs that we get on our patient, what's that called?
Level of consciousness.
How about baseline?
Okay.
Our baseline vital signs. Why is this called baseline?
Because this is the first one you get, and the next one is going to be, you're going to be looking at trending.
Yep. So the very first measurement you get, you're going to measure everything else against. So if you take vital signs right now and you take them again in 5 minutes and something has changed, it has changed as compared to your baseline. Because you have no idea what happened before you got there. You don't have any idea what their vital signs are normally. So all you can do is base it off what you have seen, what you've measured. So this first set of vital signs is your baseline. Okay, questions about secondary assessment?
Not right now.
Not right now? All right. Do you want to go ahead and press pause or stop or whatever we're doing? Let's stop it.